This slideshow is intended to provide background information on disease modeling that the University of Minnesota and the Minnesota Department have done in partnership to understand the COVID-19 epidemic in Minnesota. The work presented in this slideshow reflects assumptions and data through March 30th, 2020. As this is ongoing work and as the COVID epidemic will evolve, the model will be refined and populated with updated information and data. So results, scenarios, even assumptions may change over the next couple of weeks. My name is Stefan Gildemeister. I'm the state health economist at the Minnesota Department of Health. And helping with the narration are the PIs at the University of Minnesota School of Public Health, Dr. Eva Enns and Shalini Kulasingam, who will provide additional detail on the methodology underlying. What this presentation will cover is some background information on the approach and how we ended up deciding to develop a model in Minnesota. Some technical assumptions used in the work to date. We'll present results of 2 scenarios and then we'll conclude. As the pandemic, the COVID pandemic, has been evolving, increasing number of researchers and experts have developed mathematical models to forecast the epidemic and inform policy responses to manage it. Some of these models differ in their assumptions, many differ in the approach, certainly some differ in the terms of results that they project. So we wanted to take a step back and ask, what are these kind of models? And in its most basic form, mathematical models used for disease forecasting, built on observed evidence of disease characteristics and progressions of diseases, together with past evidence of how diseases interact with people and environments, and layer on top of it mathematical techniques to forecast disease outcomes. In general terms, all estimates are associated with uncertainty, so it's important to recognize that these, however sophisticated models are intended to provide general information and should not be viewed as crystal balls that can give us precise results of timelines or number of affected people. The model, generally models are used to inform current disease outbreaks, just as is the case currently with the COVID-19 epidemic, but they're also oftentimes used to plan for future outbreaks or respond to outbreaks as they might reemerge through immunization campaigns or others. This model in particular emerged from the need of the administration and Commissioner Malcolm, the health department, to inform policy decisions through and epidemiologic responses through forecasting. Staff at the Department of Health looked at a range of models and model results and findings and considered the literature and experience in other states. We settled on the model that the university has been building out for a number of reasons. First of all, it was already pretty advanced in its emergence, but also we really valued the ability to work with an interdisciplinary and highly collaborative team that permits us to fine-tune inputs in the model and model assumptions, that is committed to building a dynamic interaction with the model where we can test various potential reactions or responses or varying assumptions in the disease to understand its sensitivity. And most importantly, we find it important that under the University of Minnesota model, we are able to customize the model to the Minnesota experience. That means both in terms of what we're observing about infection rates and hospitalizations and mortality, but also to seed the model with actual age structure as we observe it in Minnesota and the underlying distribution of conditions that make people vulnerable for the disease. And then over time, as we think about refining this model through a range of additional data and assumptions, including to demonstrate uncertainty around estimates, we also plan to inform the model through actual contact patterns that we observe in the Minnesota population.
Our model follows an SEIR structure, which reflects susceptible, exposed, infected, and recovered stages of disease. This structure has been used to model other coronaviruses like SARS and MERS, and is the same structure used by the Imperial College model and many of the other models that you've seen publicized. The key here is that we include this exposed stage, which is the incubation period prior to the onset of symptoms, and gives us that delay between someone's initial infection and when they would develop symptomatic infection, potentially being identified and requiring critical care. Our model assumes an average latency period of 5 days and an average infectious period of 8 days. Model parameters are generally set so that we have an R0 of about 2.5, though this calculation is somewhat complicated by the age stratification that we have in our model. We include stratification by age to account for the differing levels of severity by different age groups. So on the right, we have a table summarizing the rate of hospitalization, ICU care, and mortality by age that we use as inputs into the model. We assume an average ICU recovery period of 23 days, and we also include the effects of elevated mortality if ICU bed capacity is exceeded and due to the presence of underlying conditions. Our model is parameterized with the demographic characteristics of the state of Minnesota, as well as the prevalence of underlying conditions in the state of Minnesota by age. So in scenario 1, we model no mitigation, including the social distancing strategies that we've been engaged in thus far. So this is really with no change to contact patterns at all. Under that scenario, we're estimating a time to peak epidemic of about 9 weeks and a time to reaching the state's current estimated ICU capacity in about 5 weeks. And again, these estimates are both very uncertain and preliminary in our estimation. These figures show some output from the model. On the left, we have the number of hospitalized patients and the number of patients needing ICU care over time. And then on the right, we have the number of active infections on any given day. And again, we want to emphasize that these are uncertain projections. And again, we'll be refining these estimates in the days and weeks to come. In the next scenario that we modeled, we looked at the significant mitigation that was started in the state on March 27th, where we assume an 80% reduction in contacts, followed by an additional 3 weeks of the social distancing we were doing prior to that, which we're assuming reduces contacts by 50%. Following that, which would be projected to lift on May 1st, we're then assuming continued social distancing for vulnerable populations with a reduction in contacts of 70%, but only for that particular population. Under these conditions, we would project a time to peak epidemic, again, of about 14 weeks, and a time to reaching ICU capacity, still assuming the same state-level ICU capacity of 11 weeks. Again, highly uncertain, and this is also assuming that we're not increasing the state's ICU capacity in the meantime, which is, of course, an intention of the governor. Again, here are outputs from the model showing the number of hospitalizations and ICU demand, as well as the number of infections over time. The primary difference between these figures under scenario 2 versus scenario 1 is that they're shifted in time. So we're delaying this peak infection and peak hospital demand.
Thank you, Dr. Enns. I will take a few more slides to wrap up the presentation. So I think the data and the modeling that we've done and that others have done should drive a few points home pretty clearly. The COVID-19 pandemic looks like it's going to have severe impacts for Minnesota that will cover an extended period of time. The impacts on individuals who require health care, on individuals who get very sick, on the system to support them all will be real challenges like we have not faced in a really, really long time. So given this, I think we should take the pandemic seriously and be mindful to look for ways to ensure that we can weather it as well as we can. It's also important to acknowledge, of course, that a response to the pandemic will have its own challenges. Isolating people from their work, from their families, has economic, has personal impacts. These are extremely disruptive times. But nevertheless, doing nothing is not an option because it would ravage the healthcare system and really affect tens and tens of thousands of Minnesotans. So the governor's significant smart mitigation strategy is aimed at accomplishing three things: pushing back the peak of the disease, and thereby allowing us time to ramp up needed healthcare capacity to provide care for people who have hospitalized and require significant ICU treatment for respiratory illness, to improve existing treatments if that's possible or add new ones, and to explore a range of strategies, including on testing and isolation, to reduce the long-term impact of the pandemic. I want to conclude with a few final thoughts and reiterate what Dr. Enns has said. Any mathematical models produces estimates that are associated with considerable uncertainties. That's true here as well. The estimate of individuals affected and the peak, when we expect the peak to occur, all of those are associated with weeks of uncertainty and thousands of people of uncertainty in either direction. In the next version of the model, we'll illustrate that to really help users of the data understand its potential impact. Anyone looking at this data, looking at the model, looking at other models, should recognize that these models are not really intended to act as crystal balls for events or level of impacts, but rather as general directions against which we could assess the relative effectiveness of various policy responses. The other thing that is really important to remember is much is new about the pathogen, and the epidemic in Minnesota is very new as well. So as the disease evolves across the globe and takes a foothold in America, more data will emerge that will help us develop a more refined understanding of its potential impact, but also how it might be different in Minnesota because of how we respond to it early and intentionally, how our population responds to the mitigation strategy, and the fact that we're much less densely populated than New York City, for example, and to consider how different strategies could continue to have an input. It's fair to say that no model fully captures policy considerations. So we sketched out the cornerstones of what the Walz administration's strategy is that will evolve. That's the commitment the university has made to us, and we are working on a number of scenarios that vary assumptions around how long the mitigations are in place, how severe they are, what supports might be in place for people affected by the disease, etc. So this is ongoing work. And it's ongoing work in the sense that we continue to validate projections and assumptions against other models. We continuously, virtually daily, update inputs and assumptions, that we revise key parameters as we see evidence evolve across the globe and expand our list of potential outputs from the model. Clearly, it's important to understand when the endemic peak might occur and how many people are affected, both in terms of their mortality but also healthcare use. But other questions are equally important, such as what's the differential impact of the condition of the disease and the pathogen across Minnesota? How might the disease respond to a range of isolation techniques experienced by individuals? What's the economic impact of the isolation on Minnesota and Minnesota residents? And what are the unintended consequences of long-term isolation of the population? So this is ongoing work. Estimates will change. In fact, this model has been designed so that it can be dynamic and that it can take into consideration expected changes in ICU capacity, anticipated changes in response to the administration's mitigation strategy. The hope is that the last word definitely will not be that as many as 50,000 individuals in Minnesota will succumb to the disease. So we expect to be able to bring additional evidence from how effective the current mitigation strategy has been and how further mitigation, either in a targeted or in a more comprehensive and broad-based way, can help Minnesota weather the pandemic in the best possible way. So we look forward to staying in touch with experts and colleagues, and here's contact information both for the media departments at the University of Minnesota School of Public Health and the Minnesota Department of Health. There are also links to the investigators involved in this ongoing work. Thank you so much for your interest. We hope this information has value, even though it's fairly high level. We anticipate following up on it with some formal documentation material that will carry what we're saying here on top of a number of slides, make it more comprehensive and easier to understand. But again, if there are questions, we're welcoming them, and we look forward to answering.